Hi, my name is Dr. Krina Patel, and I'm an associate professor at the UT MD Anderson Cancer Center here in Houston, Texas. And today I just wanted to spend a couple of minutes talking about just the amazing things that are happening in the treatment for multiple myeloma patients in 2023. I think most people here would agree that the last decade has just been phenomenal in terms of finding better therapies early on in induction therapy, transplant, maintenance, and all the relapse refractory things that we've been able to improve on for survival, but also just as important, quality of life for our patients. And even though we're not able to say we've cured patients yet, I'm hopeful that some of our new therapies maybe have cured some patients. But what I'm even more hopeful about is that as we do more and more research with these novel immune therapies that we've had, CAR T cells, bispecifics, antibody drug conjugates, we're learning so much every day. And the future of combination therapies or bringing some of these therapies up front or earlier is going to change everything we do. And just a couple of different patient groups that I think that now we have these opportunities to really delve into why do different people respond differently. And I think in the clinical world, in terms of phase 1 and 2 studies, we have all these new targets that we found for myeloma. So it's not just BCMA anymore. We have these great trials with GPRC5D CAR Ts. Of course, the bispecific with GPRC5D, and hopefully we'll have that coming down the road as an FDA approval in the next year, which is fantastic. But then also, again, like I said, the combinations of bispecific therapies and CAR Ts coming earlier, and we have more trials now reading out for especially high-risk patients where I can't get them to CAR T, in the relapsed refractory 5th line because their disease is just incredibly hard to treat by then. But when they get CAR Ts earlier, they actually do really, really well, and it changes their outcome, and it's just really amazing to be a part of that. The other groups, I think there's some vulnerable patient populations where we don't include them in clinical trials, and hopefully that will change soon. We are all working with the FDA to help us improve enrollment for patients with renal failure, CNS disease, African American patients where we know it's a higher risk of myeloma as an individual compared to all the other patients that get myeloma, and really coming up with ways to improve that access piece. But I do think that there's been a lot of retrospective studies now that have come out for CAR Ts, for instance, for patients with renal failure that actually can do really well with some of our therapies. And I'm hoping that once we have more bispecific patients we've treated as standard of care, we'll start seeing that data come out. And then the last really thing that I want to talk about is the healthcare disparity. And I think in myeloma, again, because African Americans have a higher risk of multiple myeloma as an individual, we really need to do better getting patients onto clinical trials, but then getting access for all of these novel immune therapies. And I think, really looking into this in a deeper way. And I'm excited that I have a fellow who is doing her entire 3 years of fellowship looking into all the different projects that we can do to help with this exact question, because it's not one issue, it's multiple. And I think we owe it to our patients to really delve into that and come up with solutions. And so with that more higher level, discussion on all the amazing things that we as a community are doing, and this is not everything, but some of the really important topics that are that I believe are things that we really need to focus on. I wanted to go a little bit more into detail on some of the most exciting research trials that have come out, mostly for new targets and new therapies in the last probably 6 months. But really, kind of going to the other targets. So again, BCMA, fantastic. But we really don't know how to sequence these different drugs. So we know that the BCMA therapies for majority of patients, again, is unfortunately not a cure as we were hoping it would be. It has given us some of the best results for our patients more than anything else ever has in our relapse refractory patients. But this means that after people relapse on whatever BCMA therapy they have, they need another therapy. So the question comes up on sequencing. And my fellow, Chris Ferrari, actually presented at ASH on some of the retrospective data on sequencing. And there's been trials like the elranatamab, the teclistamab, different cohorts on these studies for the bispecifics that look at patients who've had prior BCMA therapy. Same thing with cilta-cel and prior BCMA therapy before cilta-cel CAR T. And the common theme, these are all small numbers in these different evaluations, but the common theme is that the response rate is still higher than anything else that we've ever seen, but it's maybe 10% less. So if something, gave a response rate of 60, 70%, then maybe that bispecific now with prior BCMA therapy would be 50%. Again, 50% is still higher than our past norm of 30% to get FDA approval. So it's still a great option, but that means there's something going on in that mechanism of response that could really affect how we should be sequencing these therapies. And it's not just the T cells, which the health of T cells matters, and possibly timing of, when you give someone a bispecific, and then when they relapse, when you have to wait until that you can make CAR T again, or if they get a CAR T and they don't get a great response, can you give a bispecific right away, or will they have more toxicity? These are all questions that hopefully we'll be able to answer in the coming, months to years. But now with these new targets, it takes out that question of BCMA loss. And with BCMA, we don't have great mechanisms of resistance. It's not like CD19 where we see this huge loss of CD19 or complete loss of CD19. There's some anecdotal cases of it that we've seen in mostly 17p patients because of the BCMA being on 16p. And I think Nizar Bayless and his group in Calgary have done a great job. They've presented recently at IMS and I think again at ASH on point mutations that you can have in BCMA. So we're learning new ways that you can have resistance, even though it looks like you still have BCMA expression. But if your T cells can't actually, get connected because the bispecific can't get to it or the receptor for the CAR T can't get to it because of that point mutation, well, we need a different target then. And so I think as we learn this, the fact that we have new targets, I think our lymphoma and our leukemia docs are a little bit envious of us now. And the two main ones again are GPRC5D and FcRH5. And I won't go too much into the targets, but in terms of the early clinical data we have, a paper recently came out in the New England Journal of Medicine just around ASH on talquetamab. And one of my colleagues and friends, Ajay Chari, presented that at ASH as well. And again, these multiple patients, I think it was 50% or more patients had prior BCMA therapy, and they still had great response rates above 50, 60%. The toxicity is different because it's a different target. They don't seem to be fatal toxicities. We actually see less infections, which has something to do with the actual antigen, I believe. However, the toxicities are more skin-related and nails and weight loss because of taste changes, et cetera. So still things we need to work on and figure out how to do this in the real world and make sure our patients have good quality of life. But just phenomenal to see that we have these amazing responses where patients can go into deep responses and then do really well for, again, years potentially. And so that was a great thing to see. Then the GPRC5D CAR T data has come out. So Sham Malankadi at Sloan Kettering, one of my colleagues who does a lot of CAR T, I was really excited to see this, was a phase 1 study for it. And really, again, we don't see those side effects that we see with the bispecific, with the nail and skin changes and taste changes as severe. It seems to resolve if patients get it. However, a couple of patients did have more neurotoxicity. And again, we need to learn a little bit more about this GPRC5D expression. But then we also had a presentation from the GPRC5D CAR T study that was presented by Dr. Costa at ASH. And again, just phenomenal response rates for patients who are post-BCMA therapies, some CAR T, some bispecifics, and deep responses. So again, we can rescue these patients. They have other options that really do work at, again, much higher levels than prior therapies. So, just really exciting to see GPRC5D becoming a bigger target and just more to learn from that. And then, of course, FcRH5. So cevostamab is the big bispecific that has been in phase 1 and now phase 2 studies that we are hoping to get FDA approval after the study completes. But again, this is a target that is mostly on mature plasma cells and potentially B cells that doesn't really cause major toxicity. Again, we do see some CRS. They had a study looking at, Suzanne Trudell actually talked about a study with giving TOCI preemptively to see if we can decrease the risk of CRS with bispecifics. And it showed that it did decrease the risk of CRS, so maybe this can become an outpatient strategy. Still a lot to learn. We want to make sure we don't increase infection rates, et cetera, but just, we're learning a lot in terms of how do we apply these therapies in the future for our patients. And then the last thing I'll say about the cevostamab study is that it's a fixed duration therapy, and all their trials have been showing fixed duration, meaning that these patients usually get therapy for about 17 cycles or a year, and then they stop. And the big difference between CAR T and bispecifics in terms of quality of life really has been the fact that CAR T is a one and done. But if we can figure out how to do fixed duration instead of continuous for bispecifics, I think we would really improve quality of life for our patients as well. So with that, I just wanted to say that it's a really exciting time for researchers like myself, but really mostly for our patients. I'm hoping that one day, with learning all of these things and how we combine sequence, we can get rid of every last plasma cell and finally be able to cure many, many, many of our patients. And with that, I just wanted to thank you all for watching, and to please subscribe to our YouTube channel to see more videos on multiple myeloma.